So, welcome you all to this live webinar. And in fact, I won't say that this is a webinar. This is a a journey of three friends. And as all of you have flyers in the group, that today we are going to learn about high altitude humidity. At the upfront, I would like to thank CCI, Dr. Narayan Pradeep, Dr. N.S. Krishna, and everybody from the team CCI who had given us all this opportunity to be a part of this wonderful discussion which we are going to have. And at the very upfront, I would like to introduce to you three friends, Arun, Priyank, and Nitin. Three of them, all of them are in their mid-40s, and they had planned their Everest base camp since summers are going on, and this is the peak season for traveling to Everest base camp. All of them reside in different parts of the country. Arun belongs from Bengaluru. He is a 45-year-old male, however, he's a smoker and is a known asthmatic. Prior to his travel, he plans to visit Dr. Hirennappa, who is one of our panelists. Dr. Hirennappa is a consultant pulmonologist at Manipal Hospital and Baptist Hospital, Bengaluru, Inspire Specialty Clinic. And during his pre-consultation and pre-assessment, Dr. Hirennappa shares lots of insights with Arun, which we are also going to learn. Then his friend Priyank, who hails from Hyderabad, he's a 45-year-old gentleman. He's a healthy young adult with no known comorbidities, and he visits Dr. Srikar. Dr. Srikar, he's a senior consultant intervention pulmonologist practicing at Apollo Hospitals, Hyderabad. And during his pre-assessment, he shares wonderful tips and insights with him. Then the third friend, Nitin. Nitin hails from Navi, Mumbai, and he is a 46-year-old man. The peculiar thing about Nitin's case is that he is a post-COVID survivor. He had severe lung damage during the second wave of COVID, and he has survived that. And Nitin approaches Dr. Shreeja Nair. Dr. Shreeja Nair, she is associate professor at MGM Medical College and Hospital and also consultant at MGM Hospital and Research Center, Belapur, Navi, Mumbai. So since Nitin is a case of post-COVID lung survivor, so Dr. Shreeja Nair evaluates him in detail prior to giving him fitness for travel to the Everest base camp. Now, all three of them, after being declared fit to travel for the Everest base camp, they reach Kathmandu. And after reaching Kathmandu, they get introduced to the chief pulmonologist at the base camp itself, at the Kathmandu. The people, those who have organized them, they have invited very special guest, who is also the special guest of today, Dr. Ram. Dr. Ram Narayan Shah, he is a senior consultant pulmonologist practicing at Madhepur, Nagrik and Everest Hospital. And he is being invited at the base camp at Kathmandu to address to all the participants. And do you all know the wonderful thing about the people, those who are going to start this trek? One of them is a doctor, and he is a practicing pulmonologist who is also with us today, Dr. Ajit Yadav. Dr. Ajit Yadav, he is a consultant pulmonologist, assistant professor at MMIMSR, Maulana Ambala, Haryana. So all the participants of the trek will have the wonderful opportunity to not only be a part of the trek, but also during the trek, get regular insights as well as free consultations from Dr. Ajit Yadav. So with this background, I would like you all to learn this case, which we are going to play in few moments. Please play the video.
Thank you, Dr. Ankush, for your kind introduction. It is my always pleasure to be part of CCI, led by eminent faculties. First of all, I would like to thank Dr. N.S. Krishna, sir, the trustee president, and Dr. Narayan for this opportunity. I must also thank Dr. Atri, Dr. Ashish Dubey, and Dr. Anil Maske. So today we are going to talk about high altitude pulmonary edema. So my topics start from the high altitude pulmonary diseases. 64-year lady was admitted in our hospital with chief complaints of headache, nausea, vomiting, giddiness, insomnia, fatigue, and breathlessness. Patient had history of traveling to Mount Everest, the 10th highest mountain world in the world. It's 8,091 meter and 26,565 feet. Patient was known case of hypertension and dyslipidemia. On examination, general condition was patient was anxious, irritable, confused, and vital signs were blood pressure was 170 by 110 of mm of Sg, and SpO2 was 84% at room temperature after acclimatization to 1400 meter. Heart rate was 124 beat per minute, and chest was bilateral crepitations. Cardiovascular system was S1, S2, no murmurs, and central nervous system was GCS was eye opening 4, verbal 5, and motor response 5. Now we are going to talk about the high altitude pulmonary edema. It's a potentially fatal form of severe high altitude illness, non-cardiogenic edema caused by hypoxemia. Anyone who travels to high altitude, whether a recreational hiker, skier, mountain climber, soldier, or worker, is high risk of developing high altitude sickness. High altitude pulmonary edema is the abnormal accumulation of plasma and some red blood in the lung air sacs due to breakdown in the pulmonary blood barrier triggered by hypobaric hypoxia. These breakdowns develop from a number of maladaptive sympathetic tone, exaggerated and uneven pulmonary constriction, inadequate production of endothelial nitric oxide, and overproduction of endothelin, and inadequate alveolar fluid clearance. The end result is patchy accumulation of extravascular fluid, alveolar spaces that impairs gas exchange and can, in severe form, prove fatal. The person usually notices fatigue, weakness, and dyspnea, and exertional orthopnea. Condition typically worsen at night, and tachycardia and tachypnea occur at rest. Patient may complain of chest tightness or congestion, cough, frothy sputum, sinuses, rales, and dyspnea progressing to severe respiratory distress. Now, we should talk about the hazard of the high altitude. So what is high altitude? It's height above 2,700 meter or 9,000 feet, and how it is different. So we all know that it's a low atmospheric pressure, less quantity of air causes breathlessness, very low temperature in winters, it goes up to -30 to -40, high intensity of sun rays, low humidity, high velocity of wind. And what 4 factors affect our response to altitude? The altitude you move, your rate of ascent, the altitude is slept at before moving to the new altitude, individual factors such as your genetic makeup and the physiology. Obviously, we should think about the genetic because the Sherpas are more comfortable with height in comparison to others. Individual risk factors. How does your body regulate heat? We have to follow it also, heat gain versus heat loss. And how does your body respond to cold weather environment? What types of cold weather injury can you sustain? And how do you treat them? What other individual factors make you more or less susceptible to cold weather injuries? Now, how do I treat high altitude pulmonary edema? Do not delay treatment. This is an medical emergency. Move the patient down a minimum of 1,000 to 1,500 feet immediately. Administer oxygen. Use a hyperbaric chamber if one is available and if immediate descent is delayed. This one is a simple high altitude pulmonary edema bag. Here we can see that there are relief bags, windows, tie down straps, zipper, and there is also the optional intake valve and also the sphygmomanometer included inside. So that this is one the bag that if a patient is sick, we used to put the patient in this high altitude pulmonary edema bag. And obviously nowadays we have seen so many complications also regarding the high altitude pulmonary edema post-vaccination of COVID. And one of them is the pulmonary embolism is one of the three major cardiovascular cause of death along with the MI stroke. Recently on 19th April, Irish climber died and it was diagnosed as whether it was MI or PE. Now, source of thrombus, 90% of thrombus forms in the lower limbs, 60 to 80% of femoral vein, and 33 to 45% of calf DVT is embolized. 50% of patients with DVT have evidence of pulmonary embolism. Now, again, we are returning back to our patient. We did the routine investigation, CBC, RFT, LFT, PTINR, ABG, CRP, random blood glucose, sugar, ABG, severe hypoxemia and respiratory alkalosis. Chest X-ray showed bilateral infiltration with normal heart size. ECG was approximately normal. On the CBC, we found that there was mild leukocytosis. RFT were approximately normal and PTINR was also normal. Now we are moving toward the treatment. Yeah, obviously, first we started oxygen supplementation was started immediately, though the patient was brought in the oxygen condition. IV antibiotics were started, IV diuretics were given, tabacitazolamide was started, and obviously tadalafil, dexamethasone, and nimodipine was started. Now, one thing that the point to be remembered, personal hygiene before going to the upstairs or high altitude, we should think about the personal hygiene, sponging, antiseptic bathing, haircut, nail care, infection, fecal-oral contamination, nail cutter, body care, drinking water, very essential, at least 6 to 8 liters per day. Increase the hemoglobin viscosity and avoid the dehydration. Layered covering with warm clothing, avoid inactivity. Movement is important. At least 250 daily walking at the region. Thank you.
Okay, thank you so much, Dr. Ram. This was a wonderful case presentation, and we got to learn about high altitude pulmonary edema. And we continue further the discussion. We'll be having few more questions about high altitude pulmonary edema. And now, as all the three friends have already reached the Kathmandu base, from where they are going to start the Everest base camp trek, there are multiple other people, those who are accompanying them for the trek. One question which we have, since Dr. Ram, you are there for guiding them up front, what are the major challenges at high altitude? Dr. Ram.
Yeah, major challenges at high altitude is always there is the deficit of oxygen. First of all, thing that as we climb to the upstairs, there is always the so that we have to think about the oxygen level will be decreased. Obviously, there will be the what we say that sun rays and ultraviolet rays will be there, and obviously there will be the cold extremities, so that we have to take precaution about those things, that and we need to take the sunglasses and winter clothes, that it should be covered each and everything, our whole body. So these are the things that we have to consider, and we must not forget about taking adequate amount of fluid. That is, the water is the most important factor that we have to carry it out. And before going onward, that we should have the practice of whether we should be mentally prepared for the high altitude hiking, so that we have to consider these things.
Fine. Thank you so much. So, Dr. Hirennappa, since your patient, when he approached to you at your clinic, you explained to him something very peculiar, that is oxygen cascade. So, sir, kindly tell us, what is this oxygen cascade at sea level and at high altitude also, and also more importantly pertaining to the pulmonary diseases at high altitude, like whatever you explained to your patient. So please explain to us also, Dr. Hirennappa.
Yeah, so whenever any pre-existing lung disease is there, they are more prone to complications whenever they are going to high altitude. As far as normal people also, they can end up in having a problems if their ascent is very high. But especially pre-existing lung disease like asthmatic, here the patient is a smoker, we told him not to smoke. And asthma assessment on ground, they do lot of things at sea level, because they have doctors are available, they can take inhalers, they don't about lung functions. Normally, nature has given us some reserve. Even if they doesn't take their inhalers and all, they don't feel our reserves are not come into actions, and they do their routine activities very well. And when they really go up, the reserves are at risk. At sea level, what happens? Normally, the FiO2 is around 21%. Okay, so the barometric pressures, if you measure that, it is 159, 150. This when you go on high altitude, the FiO2 decreases. At the peak of Mount Everest, it is a 6% FiO2. At more than 2,500, this is 15%. Like flight, it is 15%. It's pressurized cabin. So the available FiO2 at outside, which we are taking in along with nitrous oxide and other things, the FiO2 available will be less. So the oxygen always travels from the high concentration to low concentration. That is the oxygen cascade we talk about. So we take FiO2, this thing goes into the lung, airway, we have alveolar O2. Then there is a gradient. When it crosses, it always crosses barrier and reaches the alveolar capillary membrane. Ultimately, this cascade has to go to the last common denominator, that is the cell and mitochondria, where the pressures are around 10 or 15. So the pressure gradient has to be mentioned. A lot of things are involved based on biologicals and adaptations and other things that happen. So when you go to the high altitude, the input FiO2 is only less. It's not about 100. So the body will feel the shortage, and the body will automatically, to have a aerobic respiration, it will ultimately go to an anaerobic threshold, and we have lactic acidosis, all kinds of problems with all organs of the body will be affected, because the main function of the lung is deliver the oxygen to the last common tissue in the body.
Wonderful. That was very wonderfully explained. So, Dr. Srikar, when this patient Priyank, he approached to you in your clinic for the pre-travel assessment, he asked you that what are the physiological changes which will happen at high altitude, which we called as acclimatization. So please throw some light on that, sir.
Yeah. So when we talk about the physiological changes at high altitude, we have to consider it. I mean, how the whole body adapts. It's not just the lungs, it's the whole body as a whole. So we talk about it. Let's start off with let's subdivide it rather. So we'll start off with ventilation. So ventilation, basically, as we are all aware, it is a centrally mediated process, but we have got a very good peripheral regulator which senses a decrease in the oxygen levels at that altitude. So as Dr. Hirennappa has just mentioned about the decreasing FiO2 as we ascend to a greater altitude. So the carotid body, okay, is the first this is the first defense mechanism to detect a low level of oxygen in the blood. This is also enhanced by the fact that the carotid body receives a larger amount of blood per gram per kg body weight. That's almost like 1200 liters of blood per kg. So the whole reason for mentioning this is the carotid body is extremely sensitive to hypoxemia. So the carotid body, once it picks up this hypoxemia, it is going to relate to the central chemoreceptors, and these are going to increase the ventilation of the patient. So it means that the depth of breathing increases, the tidal volume and the respiratory rate both increase, and as a result of this, there is flush out of carbon dioxide. Now, what happens when there's flush out of carbon dioxide? Once again, hypocarbia is picked up, and then that acts as a hindrance. So further ventilation is limited. So how does the body combat this? The body starts excreting bicarbonate through the kidneys. So bicarbonate diuresis basically provides that stimulus for further ongoing ventilation. So we also start having a lower PCO2 levels along with a lower bicarbonate level. So this is going to ensure that deep breaths are taken and we breathe at a faster rate to make sure that whatever little oxygen is available in the ambient air at high altitude is delivered to the lungs. So this is about the ventilation. Now moving on to the circulation, we once again, of course, circulation, as doctors, we know it is again subdivided. We have the systemic circulation to think about, we have the pulmonary circulation to think about, and the cerebral circulation to think about. So as for the systemic circulation, just because we have just spoken about diuresis, and also a short note that we will be taking a medication, for example, like carbonic anhydrase inhibitors like acetazolamide for that matter, which by itself is also going to cause a bicarbonate diuresis. So the reason why I mentioned this here is that the circulating blood volume is going to decrease. So the body is going to be relatively dehydrated, which comes back to what Hirennappa sir has just mentioned, that we need to hydrate ourselves very well. Also, there is loss of water via the lungs too because of increased tidal breathing and high respiratory rate. So all this causes a relative hemoconcentration. So initially we have, let's say we take a blood sample at that altitude, we are going to have a relatively higher level of hemoglobin and red cell mass, but this is only a relative increase. The actual increase in red cell mass is mediated by a very interesting molecule which is known as HIF, hypoxia inducible factor. So this basically triggers off a cascade of numerous genes and all. So we won't go into the genetics aspect, but just to simplify, this makes sure that the red cell mass is increased and more erythropoietin is secreted, and as a result of this, the red cell mass is increased. So more red blood cells ensure that more oxygen is delivered. So systemic. Now coming on to the pulmonary circulation, because of the low levels of oxygen, ambient oxygen, we have got a very interesting mechanism once again, which is known as hypoxic pulmonary response, or the hypoxic pulmonary vasoconstriction. So this is going to increase the pulmonary artery pressures and going to cause a relative strain on the right heart. So coming back to the corollary, the case which was so wonderfully discussed, exercising or undue exertion in an unacclimatized individual is going to further increase these pulmonary artery pressures and predispose them to high altitude pulmonary edema. As far as the cerebral circulation is concerned, the cerebral blood flow does increase. It almost increases to a tune of 20 to 30%. The highest increase in cerebral circulation was observed in the hypothalamus, closely followed by the thalamus. And the only problem here is cerebral autoregulation gets disrupted, which means that the brain is not going to respond that effectively to changes in the systemic blood pressure. So we need to be a little careful here. And as far as the blood, the hematopoietic response, the last topic which we'll talk about in here is that the hematopoietic response is basically related to the production of erythropoietin, so which is secreted by the kidneys. But by the time we have reached this stage, it means that the body has already sensed that we have got low levels of oxygen in the atmosphere. Two very interesting molecules, that is hepcidin and erythroferrone. So these two are the molecules which basically make sure that the iron metabolism is stepped up in situations of hypoxemia. So these basically increase the red cell mass and take on the function which is prescribed. Oxygen dissociation curve, that's the oxyhemoglobin dissociation curve. This also is very interesting because at hypoxemia and under this stress, we got an increase in the 2,3-DPG, 2,3-bisphosphoglycerate. So that is going to push the curve to the right initially so that more oxygen is released to the tissues. But at the same time, ultimately, we are going to have a left shift. So left shift of the curve is extremely essential for adequate acclimatization. In fact, the animals, like this was an animal study, the altitude adapted animals had a significant left shifted oxygen dissociation curve. So as a result of this, these changes are necessary for normal survival at high altitude and also for exercise. In exercise, we have got an initial decrease in VO2 max to a tune of almost 10% with every 1,000 meters of ascent. So a stay at high altitude, it takes almost 1 week for the body to get acclimatized, but one can never perform at the same level which he had done at a lower altitude. So this is one thing to be.
Amazing. That's very comprehensive. And as we were listening to the trek has to the answer, the trek has already continued. Yes. And listening to all this discussion, the participants have asked Dr. Ajit, because he's a group part of the group, that please describe the pulmonary diseases spectrum at high altitude and which all are the susceptible population to developing these diseases. Dr. Ajit.
Good evening, sir. Respected teachers. I think I'm the more junior most person here. So regards to all the senior person and CCI and Krishnan sir. So the person with the pre-existing diseases, like person with the COPD patient, there is an increased mortality and the incidence of core pulmonary is always there. So 25% of the COPD person with a mild to moderate severe COPD person will face this decrease in a PaO2 level of 55. It is recommended to continue with their inhalers to take with them. Also take prednisolone with them. And it is also advisable to take the nifedipine if in case they are having pulmonary artery hypertension. But they may not be having the symptoms of hypoxia due to the partial accumulation of due to COPD percent. So there are no such studies till now with the severe disease that there is a resting hypercapnia at an altitude of 3,000, around 3,000. Usually the studies are up to 3,000 altitude meter. And in case of asthma, the studies shown that the asthmatic patient usually can go up to 5,000 meters without any complication. The issues with the asthma patient is, as there is a low density of the air and there is increase in the ventilation, it will may precipitate someone with the exercise-induced asthma. And in case of asthma, there is a positive point is there is a less of allergens there is no pollen. So it will, but according to the study, there are only up to 5,000 meters available. Variable effects of hypoxia and hypocapnia is seen in asthmatic patient. And there may be genetic polymorphism that present in the patient with it. Same, you have to take the inhalers with them, with the asthmatic patient, and the patient also have to take the steroid in case they need it. So, in case of pulmonary hypertension, the patient who was already diagnosed with the idiopathic pulmonary hypertension, there is a case of a desaturation. The complication of desaturation is much more. And nifedipine is shown in some studies as it will relax the smooth muscle. It will help in reducing the pulmonary artery pressure as well as the pulmonary vascular resistance. So 20 milligram sustained release is used there. And there is 30% more chances of thromboembolic diseases at high altitude. So the patients with the already having some anticoagulant using they must continue there. There is an increased risk. This risk is because of the hemoconcentration, as sir just explained the physiology. There is a core shell effect, the pulling of the peripheral blood to the central core to maintain the temperature. That causes the hemoconcentration and viscosity of the blood is increases. So that in case we can protect against the pulmonary thrombosis. Another aspect is we have the sleep apneas. So patient with diagnosed with a sleep disorder has to continue with the BiPAP support as they are using. One study shows that acetazolamide is used if BiPAP support cannot be given. it will improve the status and help in more acceleration of the acclimatization. And the other part is in terms of cardiovascular risk. Sir, as we ascend, there is increase in BP and as well as cardiac output. So in first 7 to 10 days, so the ACE inhibitors and selective beta blockers are recommended, not the non-selective. And in acetazolamide again is also recommended as it has diuresis effect also. So this is in terms of conditions of the disease.
Fine. So as
If
I
anything
understood,
left, sir.
so as I understood, like the pre-existing diseases can exacerbate. Also, like Dr. Ram has already discussed about high altitude pulmonary edema. So you added to that pulmonary embolism because of the increased viscosity of blood. And then you added upon the cardiovascular complications. So fine enough. So Dr. Shreeja, your patient Nitin has just told us that he is experiencing headache. So what do you think, that could this be acute mountain sickness? And can you please throw some light on this in terms of pathogenesis, symptoms, diagnosis? Dr. Shreeja?
Yeah, good evening. Thank you, Dr. Ankush. First of all, thank you to CCI office bearers and Krishna sir, as always, for inviting me again to be part of a webinar. So I'll get straight to the question. The patient, Nitin, has headache, you said, right, Dr. Ankush? So the thing is, yes, headache is a very important symptom for a person who is, ascending to a high altitude. And it is, yes, definitely a differential diagnosis of acute mountain sickness, which is actually the most form of high altitude illness, acute high altitude illness. So you have acute and chronic illnesses. The most common one that about 25 to 50% of the trekkers and, people who climb up to high altitude face is acute mountain sickness. And that usually starts at an elevation of above 1,800 feet. And, it usually takes place between 1,800 and 4,200 meters of elevation. So it's basically characterized by headache with one or more symptom. It can be either lassitude, it can be anorexia, it can be fatigue, it can be dizziness. And we have a scoring system called the Lake Louise Acute Mountain Sickness Scoring System, which in fact, every traveler who goes up, so even this patient, Nitin, will have to, go through this questionnaire. It's a self-scoring kind of a questionnaire, which kind of warns them for early signs. So this has 4 questions, 5 questions actually. 4 of them are based on the symptoms, like I told you, all these 4 symptoms. And you have each score is from 0 to 3. So 0, for example, if the patient starts getting headache, if there's no headache, it's 0. If it's mild, if it becomes 1, moderate 2, and 3 is incapacitating. So like that, the patient has to keep scoring this at least twice a day when he's ascending. So these are the symptoms basically. And now the score goes on from 0 to 15. So 0 to 3 is acceptable. Anything above 3 to 5 shows that the patient may be developing symptoms and he has to, take to heed the symptoms. Anything above 5 means the patient is going to moderate severe acute mountain sickness. And, he needs to slow down, stop, take a rest, maybe descend. That is part of the treatment. But so these are the symptoms actually. And this all patients must be aware of acute mountain sickness symptoms. Now, AMS is actually a diagnosis of exclusion because there are a lot of other differential diagnoses that mimic these same symptoms. So like Dr. Ram had said, dehydration is a very important, a very common thing that happens to trekkers. So things like acute dehydration, hypothermia, hypoglycemia, carbon monoxide poisoning, maybe alcohol intoxication if the patient has taken, and other things like, so extreme exhaustion, fatigue. So, and even meningitis or encephalitis, these are all differential diagnoses that you must consider before just labeling a patient as AMS. So, and when it comes to clinical features, now this patient may look normal. Mild AMS doesn't really show any signs. But the patient may have hypoxia, which could also be part and parcel of the, the normal mechanism, the physiological mechanism. But yes, there could be hypoxia. The patient may have mild fever. The patient may, may show. Basically, these patients will not, however, show signs of altered mental status. So these patients will be normal. They won't be drowsy. They will be, they're normal. They have a normal mentation. Crackles in bases of lungs may be heard at a later stage, but more or less the signs are not very, diagnostic. So this is a diagnosis based on the symptoms and the Lake-Louise system. And you asked about the pathophysiology. So now the pathophysiology is not really clear in this disease. There's still a lot of speculations about why it occurs. But they found out that the triggering factor for this, the array of symptoms is basically due to hypoxemia, which has an effect. Now, because headache is a main symptom, most of the studies that have been taken place in AMS pathophysiology is related to the pathophysiology of headache in such circumstances. So they found that things like trigeminal-vascular activation, tight fit hypothesis, these are theories where you have a hypothesis where the CSF volume is compared to the blood and the tissue brain volume, and they found that such patients who have a lower level probably have altered cerebral blood flow. They're not able to regulate the cerebral blood flow properly, increase blood cerebral volume, decrease cerebral outflow. These things actually cause headache and may cause increased intracranial tension. So there's still a little gray zone regarding the pathophysiology, but there are many other things too. There could be inflammation that is taking place, the way the body reacts to hypoxemia, and even things like reactive oxygen species, vascular endothelial growth factors. All these have a part to play in the pathogenesis. So this is a little about acute mounted sickness. You don't want me to go into the treatment, right? I suppose.
Yeah. So we'll discuss that.
Yeah, sure.
Treatment we'll be discussing soon. So thank you so much for that detailed description. And meanwhile, as Nitin was experiencing headache, Priyank is feeling some amount of breathlessness, and many other participants in the trek are like a bit worried since they have heard about this term, high altitude pulmonary edema. So Dr. Ram, the next question is for you. If you can please discuss about high altitude pulmonary edema, again in terms of pathogenesis, symptoms and diagnosis. You have already done that as a part of the case which we discussed. Just please elaborate once again.
The main thing is that I have already explained in my talk that the pathogenesis, as the patient goes to the high altitude, there is we think the Starling law, and there is the decrease in the hypoxemia. It triggers hypoxemia, causes hypoxemia will cause extra fluid in the alveoli, and it gives overproduction of endothelin, and it causes shortage of breath. So that and it becomes the bilateral opacity haziness in the chest X-ray. And even though if we do ultrasound, there will be the B lines over there. So that these are the things that we have to think about it.
Okay. All right. So Dr. Srikar, like since Priyank is complaining of breathlessness, would you like to add something to this high altitude pulmonary edema, its pathogenesis, symptoms and diagnosis to what already Dr. Ram has already told? Would you like to add something, sir?
Yeah. So one important thing here is most of the time, like this is not exactly the medical fact, but this is what, even Dr. Ram sir would observe. Most of them are young and healthy individuals who decided to overexert themselves. They ignore the subtle signs because most of the time these symptoms exist in a continuum. They may they start off with symptoms of AMS, as Dr. Shreeja has perfectly explained in a nutshell, and then on probably the second to fourth night, after second night, usually the second or third night, they start developing symptoms of breathlessness. It is not necessarily accompanied by orthopnea per se. So they just brush it aside as, I'm just getting used to the altitude. Thereafter, once the two very important signs which we need to notice or rather ask for is, did you notice that your exercise capacity has come down? If yes, did you also notice that once you stopped exercising, do you feel you're taking a lot more time to recover from or come back to your normal state after a bout of exercise when compared to a baseline? So this is something like a heralding sign that the person might develop high altitude pulmonary edema if he is not careful. And apart from this, the other symptoms sir has already summarized in his presentation, but we can have a varied presentation. Sometimes we have a mixed presentation, like in a pre-existing, with a person with comorbidities, we can have symptoms of cardiac disease. He may also have coexisting heart failure. He may also have a pulmonary embolism, which is coexisting, or a thrombosis, as detailed by Dr. Ajit. And he can also have a pneumonia. Because the problem is, once we get down to the laboratory investigations, which you take in a patient with a diagnosed high altitude pulmonary edema, it can just overlap. The person can have a fever, he'll have an elevated total blood cell count, he can have an elevated CRP, and he can also have a surprisingly elevated NT-proBNP. I won't say surprising, because yes, the right heart is involved here. So it's a very mixed picture. So it's better to take all these diseases into consideration. We need to treat him for a pneumonia. It's better we supplement him with probably a prophylactic anticoagulant or a treatment dose of anticoagulant as based on the case scenario, and start treating with the drugs which have been mentioned by Dr. Ram and Dr. Ajit. So we need to give him pulmonary vasodilators first, where it is nifedipine or more selective ones like tadalafil or sildenafil. And at the same time, we need to bring him down to an altitude. Suppose we don't have enough time for that, it's better we put him in a bag wherein it's pressurized, basically exaggeration of a gamma bag, for example, for instance, and make sure that the person feels that he has already returned to a lower altitude. Along with that, we can go for normal oxygen therapy, titrate a saturation of more than 90%, and if necessary, in some instances, we can actually consider hyperbaric oxygen therapy if the facility exists. And as well as the radiological features are concerned, usually it starts off in the right middle lobe. Most of the radiological presentations there, the crackles usually start off in the axillary area, rather the infra and the axillary area, the junction somewhere wherein the right middle lobe is located. And one more interesting point, which I think we have mentioned, discussed in a couple of situations in the past, that what if the person has a absent pulmonary artery? So these people are the ones who are more prone to develop high altitude pulmonary edema. Usually the ones with absent pulmonary artery have that on the right side. So which means the pulmonary edema is going to be on the contralateral side. They'll be having left-sided pulmonary edema and other signs of a hypoplastic pulmonary artery, that is a shrunken lung, less vascular, absent pulmonary vascular markings, etc. And the treatment, yes, promptness is of importance. Along with that, we have to treat for the coexisting
treatment soon. We'll be discussing treatment soon.
Yeah.
Thank you so much for all these details. And Dr. Ajit, now since that we have discussed about AMS, high altitude pulmonary edema, since these are the diseases which are developing in the patient, those who are lowlanders, because they are now going to the high altitude, participants are asking that what are the diseases in the residents of high altitude, those who are already residing at the high altitude, and as Dr. Srikar has already discussed about acclimatization. So those who are living at the high altitude, acclimatization has already happened. So what are the diseases in the residents of high altitude? Dr. Ajit.
Sir, usually the disease in high altitude is labeled as chronic mountain sickness. Sir, I'm audible?
Yeah. Yes, please continue.
Sir, usually the definition is chronic mountain sickness. That is in the person who is residing at high altitude.
Okay.
Pulmonary artery hypertension is most commonly affected. Right heart side commonly affected, and right heart changes, right ventricle hypertrophy. Some other diseases that are usually find that some studies are with patient with a perinatal or retarded growth at high altitude. As there is increased production of erythropoietin and erythrocytosis. There is also in conjunction production of pro-inflammatory markers also available as there. Other in respects are concern is more regarding the heart disease. Congenital anomalies are more infrequent with the patient living in high altitude.
All right. Thank you so much, Dr. Ajit. And Dr. Ram, you have already discussed significantly about high altitude pulmonary edema. Can you please throw some light on the main prevention and treatment principles for acute mountain sickness or high altitude pulmonary edema? What we want to focus in this question is that what is the importance of ascending slowly, and how should one ascend actually? And what is the importance of hydration? So can you please elaborate on that?
Yeah, obviously that once a patient is getting sick or having some shortness of breath or having some difficulties or having something, immediately he should stop acclimatization to the forward. He should stop his further climbing or something else like that, and immediately have to stop and rest where they are. Do not go higher for at least 24 to 48 hours. At least they have to hold there and take rest. And if there is headache, at least they can take paracetamol or something like that. And if he's sick or motion sickness, then promethazine is much more better. And we have to make sure that plenty of water is required, enough water is required to maintain the hemoglobin viscosity and everything. And obviously, we have to think about alcohol and smoking should be stopped before planning to the high altitude. And obviously, there are few things that food also, the allergic food should be avoided, and cheese, such type of things, milk, dairy products should be avoided. These things should be avoided. And if getting really very sick, then they have to terminate their plan to climb the upstairs, high altitude.
Fine. So is there any role of pre-medication also, Dr. Ram?
Yeah, obviously there is pre-medication is there that at least they should take acetazolamide 250 mg. We all usually give them all the mountain climber or skier. They used to take acetazolamide 250 mg BD and tadalafil if needed. Shortness of breath is there, and some steroid dexamethasone that they have to take within them. So promethazine is always helpful to them. So these are at least these are the medicines that they should carry out. And obviously diuretics is required if needed.
Fine. So thank you so much, Dr. Ram. Dr. Hirennappa, sir, we took a lot of time coming to you. So the next question is for you, that please throw some light on the role of drugs which are used for the treatment of acute mountain sickness or high altitude pulmonary edema. Dr. Hirennappa, sir.
Yeah, mainly what we use in routine practice, there are a lot of drugs which are being written in high altitude pulmonary edema and other things. One is the preventive pharmacological prophylaxis. So if any healthy volunteer also, if he is really going at above 8,000 feet and still higher, the higher they climb, the higher the risk. The faster they climb, the higher the risk. The rapid ascent should be avoided. So, but they can still give acetazolamide as 250 mg BD 48 hours before the travel. And the checklists are important. What other diseases they have to carry those drugs, and which we are not going to talk. If they are asthmatics, they are definitely have to carry their acute rescue medications, and they have taken the long-term maintenance medications. And if there is any wheezing attack, they should be having a short course steroid of prednisolone or methylprednisolone. And COPD also can have exacerbations, especially the pulmonary hypertension patients. Certain conditions, sometimes we can't ignore their social beliefs and all. Sometimes we give borderline cases also. If they have moderate pulmonary hypertension, also they should carry those drugs. In terms of acetazolamide, it acts like a diuretic. It creates metabolic acidosis and in turn stimulates the ventilatory response, and we can wash out the carbon dioxide. By washing out the carbon dioxide, we are increasing the gradient, we are decreasing the gradient so that oxygen goes to the last common tissue and oxygenation is maintained. Nature is such that if anything goes haywire, it tries to get it to equilibrium. Body tries it too hard to do that. In spite of that, if you give acetazolamide definitely helps. Some people who are having a sulfur drug allergy, we should be careful. And sometimes CKD patients and all, we all take in consideration when they are traveling. We should avoid those patients who have large amount of comorbidities. Definitely acetazolamide helps, and that is the main drug which we have to use. And the second thing is pulmonary hypertension. So your COPD and ILDs and a lot of patients who have mild PAH, those kind of patients, because the important response in a high altitude is hypoxic pulmonary vasoconstriction. There is a reactive pulmonary hypertension. We should blunt that response, blunt the response of hypoxic pulmonary vasoconstriction. There are many drugs for that. One of the most important drug are nifedipine. So we should be careful if they are hypertensive or borderline hypertension. Sometimes they are more prone to hypotension. So sustained release tablet of nifedipine can be used as a calcium channel blockers because we use it for all of pulmonary hypertension. There are 20% of the patients who are initial response to calcium channel blockers. Nifedipine helps, and this can be used in the patients who are traveling. And if you blunt that response, they are more prone on not getting high altitude pulmonary edema is important. That can help. That is a second drug. Sometimes we can't give nifedipine and those kind of drug. Tadalafil, they have studies which are proven tadalafil and sildenafil can be used as 10 mg twice daily. It can also reduce the pulmonary artery pressure. It can increase the pulmonary artery pressures, and that helps us to prevention of pulmonary edema. The other things, diuretics, it doesn't help much, but we are used to giving any pulmonary edema or non-cardiogenic pulmonary edema. We are used to that. See, it can have if you have a cardiac risk factor, pulmonary edema is also common, and that is any bilateral pulmonary edema. It is very difficult to avoid not giving diuretics. Acetaminophen as diuretics, we can give Lasix and other things. Dehydration is a problem. Usually, it is not available. But if the alveolar capillary membrane is the one thing which is disrupted because of all those things, if you are not able to control the pulmonary artery pressures, there are certain drugs, and we should see other comorbidities like diabetes and other things. Dexamethasone definitely helps in the situation of this, those kind of situations, along with other management. Oxygen is important. Oxygen is also drug. Remember, oxygen is required. So they carry that small spray like oxygen, which is required because it comes like that. I say I carry oxygen. This is okay. Even in COVID also, they were asking, I will take this oxygen. That oxygen is not medical oxygen. It is for, I don't know what is the reason for that, but we need to carry the oxygen, and oxygen should be used liberally because you need to carry it. It's not available at plenty in high altitude. Actually, FiO2 is less. So oxygen, how exactly use it? And there are certain, if Ajit is going along with them, he will definitely carry that HAPE bags and all. He might put them and put the BP apparatus and push them down and get into the low altitude.
Sir, I am also carrying hyperbaric bag.
Yeah. So these are the drugs: dexamethasone, acetazolamide, nifedipine, and tadalafil. These are the drugs which are used. There are certain anecdotal evidence of salmeterol being used. It reduces the pulmonary edema. Because these are the studies which I saw, I was really surprised. And it is not apart from the asthma. Only salmeterol alone. Maybe that is the study which was being used. So you should use the drugs legibly, and it is a multimodality treatment, and certain things which can be preventive, carry the drugs. Sometimes we can't ask others. People when they want to save themselves, first they have to save themselves. So you should carry their adequate kits, and what are the kits which needs to be used. If they have pre-existing, they carry those drugs and manage it well. That's how these are the simple drugs which are used. There are other drugs which are being in pipeline. These are the main things: oxygen, acetazolamide, nifedipine, dexamethasone, and tadalafil or sildenafil.
Absolutely amazing. Amazing. That was quite elaborate. And like Dr. Hirennappa sir mentioned about the role of oxygen. So, Dr. Ajit, since Priyank is feeling breathless, can you please discuss the role of oxygen therapy and which type of oxygen delivery device is most suitable for the treatment? Does the choice of the device actually impact the outcome? Dr. Ajit.
Sir, basically, supplemental oxygen is the first line of therapy in case of HAPE. Sir, it will reduce the pulmonary artery pressure. It will reverse the capillary leak. It will reduce both heart rate as well as respiratory rate.
Okay.
So this is the first line of the treatment. Second thing, sir, I want to comment upon this. In case of the treatment of HAPE, the primary thing is descent.
Okay.
At least a descent with the 500 to 1,000 meter at least. Now, sir, how the delivery of the oxygen, sir? Basically, sir, 1% FiO2 more than the present in the air will create a descent of 150 meters down.
Okay.
So FiO2 will be more useful in case if the patient has, like in case of HAPE, the high flow oxygen is needed.
Okay.
So with the oxygen cylinder, we can get the oxygen cylinder portable that are carried that can give the flow of 15 liters per minute. So we can use the oxygen mask as well as high flow mask with them.
Yeah.
So this is my part.
Okay. So Dr. Shreeja, would you like to add something to this? that any type of particular oxygen delivery device which is more suitable, and does the choosing of the device actually impact the outcome?
Like actually Dr. Hirennappa was telling, it's not really possible to carry these oxygen cylinders and concentrators while you're trekking. Maybe at the Everest base camp where our three friends are, going to start off their journey, they would probably, because it's a commercialized base camp, they would probably have oxygen concentrators and cylinders. Actually, if a person is already acclimatized, they can usually survive up to 5,000, meters without oxygen. That's what they've discovered. Even if the SpO2 falls up to 80%, patients tolerate it. But it's severe symptoms of AMS or, high altitude pulmonary edema and haze set in, that oxygen may have to be given. But when you descend further higher, like maybe if you're trying to, target Everest and you're going above 6,500 meters, there has been a suggestion that while sleeping during the sojourn, the patients can take oxygen while sleeping. That at a very low level, because you don't want to, you want to save as much as you can. But then again, those cylinders have to be carried. The other thing I wanted to mention about is a little note on this thing called hyperbaric oxygen therapy preconditioning. So it's called HPOPC. So this is something where you have this hyperbaric chambers, hyperbaric oxygen therapy centers, which are found in some, big hospitals. And you are giving the patient or the person who's traveling 100% oxygen in a hyperbaric environment. For this is usually a 60 to 120 minutes duration. And this is like a pre-acclimatization kind of phase. So such patients, it's shown that if you give them like 2 to 7 days of this therapy, at least 1 to 2 weeks before they start ascending before they start climbing, such patients do better. They have better acclimatization because of Dr. Srikar mentioned about the HIF alpha, so it stimulates that. It reduces the lactate levels, so tissue hypoxia is better. So such patients do well if you do that. Just a note I wanted to mention. So if the patient can afford, I would suggest, that can be given. This is called,
Sure. So, Dr. Shreeja, the next question is for you only. Now the trek people are continuing their trek and they are pretty happy. So, when your patient approaches you in the clinic, what precautions and pre-travel assessment do you advise for people traveling to high altitude? And we would like to discuss this in two parts, like for normal population without any coexisting diseases, and for patients, those who have the underlying medical problems.
Okay, so for normal people, those are people, I suppose, who have no comorbidities that we know of, or at least they say so. So when a person comes to you like that, for example, the 40-year-old who's traveling, Nitin, now he may not have any symptoms or, he probably thinks he's fine, but I believe we need to give a structured questionnaire to all of these patients. So, and a basic examination. So this questionnaire is a detailed history in which you ask them a past history, whether they have any comorbidities, have they undergone any surgeries, including things like eye surgeries, any history of seizures, any history of head injury in the past, any history of any allergies to medications. For example, if sulfa drug allergy, you're not really supposed to give acetazolamide because there could be a cross reaction. So a detailed history, even a family history suggestive of A2P, a family history of any allergies, any food allergies that they may know of, because when you're on that trek, you have to do with what you have. So even the food is very important. So I would take a detailed history to start off with, ask them if they have any experience of trekking before, have they gone up to such heights? Are they trained in basic medical care or, BLS, so that they know what to do? They should be, like I said before, the Lake Louise questionnaire for acute mountain sickness AMS should be, well explained to them. After that, you should do a basic examination. So that, of course, includes your vitals. I would not just check the SpO2. I would probably tell them to do a 6-minute walk test as well, just to see, if there's any exercise desaturation. Do a basic ECG, 12-lead ECG, and also an X-ray, so that we know that there's no indolent, problems. It's known that viral infections actually worsen in hypoxia. So such patients should be ideally checked for COVID-19 status before travel. So I would ask them to get a COVID-19 and maybe even a flu status before, travel. I would ask them about their vaccination states, be it flu vaccine as well as COVID vaccination status, because again, studies have shown that people who are vaccinated with less than 2 doses of COVID vaccination in high altitude have a far worse outcome than those who are fully vaccinated. So these are some of the the signs, the workup. I think as far as prophylaxis is concerned, I think our previous speakers have elaborated beautifully about the drugs that have to be carried, so I won't repeat them again. Yes, they should be told to carry acetazolamide, nifedipine, inhalers, even salmeterol inhaler. Maybe that could also help. Even if the patient is not asthmatic, you should carry it as part of a preventive measure for HAPE. Apart from these drugs, a few things I wanted to mention was carrying other medications, such as medications for traveler's diarrhea. And if you're going to a malaria-prone area, maybe you should be carrying anti-malarials. Again, you should tell them the medications which will not cross-react with medications such as acetazolamide and nifedipine. So a basic antibiotic has to be given, something for, vomiting, paracetamol. These things have to be given. And yes, all these are the things for patients who don't have any comorbidities. Now, when it comes to comorbidities, I suppose we're dealing with lung, cardiopulmonary comorbidities are the most. So be it lung diseases, whether it's obstructive, restrictive diseases. So I think we've already discussed a bit about COPD and asthma. So now, COPD patients, I believe every patient of, cardiopulmonary patient should undergo a PFT. So that means either basic spirometry, but in a case of restrictive lung disease, like if you're suspecting ILD or like that post-COVID fibrosis patient that we have, I would definitely get it, total lung capacity and DLCO done in such patient. Okay. So this will help us in predicting the PaO2 in the, elevated area. So if the patient is traveling up to 5,000, we need to predict what the PaO2 would be over there. So for that, you need a PaO2 at the sea level. There's a formula for it called the Christophen's formula and a liquid formula. I don't remember it by heart, but it basically includes things like the FeV1. You need the PaO2 at the sea level, and this will give you the PaO2 at the expected level. So that should be between 50 to 55. So if it's less than 55 and the patient has symptoms of pulmonary hypertension, polycythemia, then what the main important thing is you have to tell them you cannot go there without oxygen. Oxygen is a must, and you have to be on oxygen. And it's shown that, every 4 liters of oxygen can increase the PaO2 by 34 mmHg is the thing that they say rise at 34 plus minus 15 is the rise in the, the PaO2. So that is one thing. In ILDs, you have to, like I said, look at the TLC instead of the FEV1 for the same, parameter. Such patients should be, of course, inhalers have to be taken for the patient. The patient oxygen is very important. And then you must tell them, maybe you cannot tolerate such ascent. You better not do it if it's not possible. So you have to be very clear and tell them about acclimatization. And such patients may do well with, hyperbaric, pre-conditioning. Like I talked about hyperbaric, there's a hyperbaric preconditioning too. It's shown that such diseases such as obesity and hypertension may kind of help in, early acclimatization in such patients. In other comorbidities, like I think we have to discuss about hypertension. I think it's already been mentioned. Hypertension, the systolic blood pressure does go up by 10 to 20, mmHg over every, after elevation after 1,000 meters. 1,000 meters. So such patients will have to carry their medication. Before ascent, they should monitor their BP and keep a check on it and carry extra medications. So, and when they return back to their, descent, they go back to their old medications. Another important point is such patients of cardiovascular morbidity, they should carry a baseline ECG with them and an echo as well. So do an echo before, near to the travel, and they should carry it with them so that patients of arrhythmia, patients who have, any changes, that they're not all changes, and it can be inferred when the patient goes to a higher level. Okay. A little worried about pregnancy. Do you want me to say? So I think in pregnant women pregnant women who don't have any complications such as preeclampsia, or PIH, induced hypertension, that is, and if they don't have any basic comorbidity, they can travel safely up to 3,000 meters. But beyond that, it's not advisable for pregnant ladies to travel. So, yeah. So this is in crux. Anything else anybody wants to add? Yeah. Because this is
ma'am, I will add one thing. In case of ILD, it is recommended to screen for pulmonary artery hypertension.
Yes, we should, yes.
If it is existing, then it is necessary or recommended to have supplemental oxygen and prophylaxis with nifedipine.
Very true. So 2D echo must be done in all these patients too. Yeah.
And ma'am, one more thing is about pneumothorax, ma'am.
Okay. Yeah.
If there is a bulla present, in case of diving, it will expand. But in case of a high altitude ascent, it will communicate. If it communicates with the airway to greater extent than expected, it will have a pressure equalization.
Yeah, so there's no, studies have found that there's no increased incidence of pneumothorax. But patients who've had a spontaneous pneumothorax shouldn't go to a high ascent within 2 weeks, unless, at least 2 weeks should have passed before they decide to take up an ascent.
Yes, that's great. So, Dr. Hirennappa, how should one assess and provide fitness to fly in patients with chronic lung diseases?
Okay. Fitness to fly, we can extrapolate it because we normally see more of fitness to fly for the flight travel. See, it's a similar analogy we can extrapolate. So whenever they are going to high altitude, and so when we are high altitude, normally we have to do a hypoxic challenge test, or if they have to create a situation where we have to do a 15% FiO2 and see how exactly they do well with their SpO2s, and that can't be done. So if they have chronic lung disease, we have lots of umpteen number of chronic lung disease because we have better medications to live them to live longer, especially obstructive airway disease like COPD and asthma. And we have parenchymal lung disease like pneumonia, and certain reversible diseases like pneumonia, recovered from pneumonia, cardiac pulmonary edema, they would have recovered. And the pulmonary hypertensions. Pulmonary hypertension, it can be primary pulmonary hypertension, secondary pulmonary hypertensions. And these are the chronic lung diseases which we are talking. So if they are well maintained and stable COPD and they are less than certain stage, and if they are not advanced COPD with a higher pH, who are oxygen dependent, unless their beliefs are so extent and they can go to the base camp and come back because their beliefs of going to certain religious area are so high that we can't avoid them. There is a lot of family tussle going on. So those patients, we can say absolutely no, and there is no shame in telling no. And you tell that it is a risk factors, you can give an alternative, counsel them. And if at all they want to go, and if they are less than COPD patients, they can carry the oxygens. If they are moderate COPD, carry their inhalers. If they get exacerbations, we should take the call and do the appropriate assessment for a COPD. COPD, we need a PFTs. And sometimes the exercise hypoxia is there, 6-minute walk test is there, may be required. Sometimes you can go up to the extent of CPET, but that's not required normally. CCG and echo to look for a pulmonary hypertension, because the pulmonary hypertension is the crux for management of any chronic disease. And pulmonary hypertension is the one thing which will get disrupted in a high altitude. So it's hypoxic pulmonary hypertension. So if anything, any disease like chronic lung diseases, right from obstructive sleep apnea to asthma, COPD or ILDs, they all have some amount of pulmonary hypertension. If they are pulmonary hypertension which is disproportionately high, say no. Or you give the medications of pulmonary hypertension lowering drug. There are umpteen number of drugs apart from tretinoin which can lower down the pulmonary hypertension. When the pulmonary hypertension pressures are high, they are also hypoxic. So there is a limitation for them to exercise, go longer or higher. So those patients we should not give a fitness. It's better not to give. So in COPD, we can moderate cases. You can give an asthmatic. They have cold air induced asthmatic attacks. If they can manage their asthmatic attacks, carry their rescue inhalers more, we can give the fitness. And ILDs, I feel it's say no to ILD unless they are young ILDs and they can sustain.
Absolutely.
You don't have a comorbidities, because exercise induced hypoxia is very high in ILDs. Because ILD, they have exacerbation, they will end up in COPD. You can still manage even for exacerbations. These are the diseases which are taken. Look at pulmonary hypertension first, looking for any other disease. If it is high, no. Better to do ABGs, PaO2s, and if they can mimic a situation on the baseline, their 91 saturation is there. You can guess if their FiO2 on room air they are not maintaining, up to 5 liters they can give, and they can last for longer. Means sometimes portable oxygen in a flight travel 8 hours we can give, but while traveling higher up, it is going to be very, very difficult unless they have multiple stations to go ahead and ascend, and they have to take a longer duration of travel if they really want to go ahead. That's how we give the fitness based on the situation, sometimes the social circumstances, age. It's not that it's the lung alone is a fitness. When you see a high altitude is a manifestation of all organs. We are not talking about the HAPE, or we are not talking about the brain. it is high altitude cerebral edema. Even if they are lung specialists which are involved in doing that, they are looking at whole things. So the lungs talks to heart and heart talks to brain. Here, this kind of situation exists. So when we are seeing if they're having osteoarthritis, there's no point in sending him for high altitude, even if the PFT is absolutely fine, ABG is fine, and other things. So we should look at overall condition and give the fitness. If somebody is aged more than 60, 65, they can't manage their diabetes and hypertensions and all. Even if their lung condition is there, say give alternative options.
Unless it's a movie situation like Unchai.
So the situation where they are the situation, so you take a call and without affecting their beliefs, we should do the fitness. And if you are able to manage the complications with their diseases, and if they have assistance, they have a good trainer and a good camp who can really take them up. You can, based on those situations, their emergency number, helpline, emergency belts are available. Based on that, we give the fitness for patients to fly with the chronic lung diseases. So we make the patient's life better. See, most of the time are religious spaces and adventurous things. It's in the young, these things. So we make their trip, this thing, they will remember us for their life, because that might be a one thing for their life they are waiting for.
This trip, we are fortunate enough that we have Dr. Ajit with them. So they all are.
If Ankush also travels, you will definitely make them not to smoke before COPD patients are there in 30 minutes. And Ajit would have definitely handled his oxygen well, and Shreeja would have given all the drugs.
I tell my patients that your travel is important. That this is usually my final dialogue. Your travel is important, but do keep in mind that your life is more. Okay. So, Dr. Srikar, on this note, as you discussed acclimatization earlier, so next question is like that: is there any human limit to acclimatization? And can you please discuss about what is ebulism?
Yeah. So basically, we are all fascinated by the concept of acclimatization, because that is what has permitted human beings to exist at a much higher altitude and comparable to their lower altitude counterparts. But yes, there is a limit, because the human being is not a machine. So that's when this concept of a lethal zone or a death zone had evolved, wherein it is quoted, I mean, it's arbitrarily placed at around 8 kilometers above sea level. Now, in the world, there are a total of 14 peaks which cross this 8 kilometer limit, and all of them are located in the Himalaya and the Karakoram range in Asia. So this is the fascination. This is where people fly from, different continents, come to Everest and try to make a summit, just like our three friends here. So, in this situation, the only meaning of a death zone is not to scare people, but it's just to mention that no human body can acclimatize to such an extent to survive independently without oxygen support at this altitude. Even by different studies which were conducted in Bolivia and all, even at the Everest base camp and all, they found that ultimately the well acclimatized individuals, those who have been living at a more than 5,000 meter altitude for over several years, have failed to acclimatize beyond this. So it is just to to bring to the notice of the general population that yes, there is a limit to which the body can take, and we should not be hasty. We cannot stress our body. We have to use our supplemental oxygen if we are planning to ascend beyond 8,000 meters above sea level. Now, the other interesting concept which I had mentioned as ebulism, this is basically, I'd call it a space medicine concept, because ebulism simply means that formation of bubbles, because you're reached such a low pressure, such a low ambient pressure, that water starts boiling at the normal human temperature of 37 degrees centigrade. So this means that the ambient pressure, as we are all familiar with this alveolar gas equation, wherein we use barometric pressure minus pH2O, and we have standardized it and calculated the water pressure to be at about 47 millimeters mercury. So of course, no human being can survive without supplemental oxygen, but this ebulism occurs at one stage wherein no human being can survive without pressurized supplemental oxygen and ambient air. So at this pressure outside, that is 47 millimeters of mercury, water boils off at normal human temperature. So water, doesn't literally boil off and convert into steam. It simply means that the water in the body, you can have large gas bubbles within the body and also within the bloodstream. So you can have arterial and venous air embolisms, which are going to hit different organs of the body. So adequate pressurization is also important apart from adequate oxygenation at this level. So this line is also known as the Armstrong's line. This occurs usually at around 18 to 19 kilometers above sea level. Nobody would venture by themselves, but yes, we do have aircraft, maybe, the military aircraft, people do travel to that altitude in the military aircraft. So they need to adequately pressurize themselves before they venture out to that altitude. This was also a classic situation wherein the unfortunate Columbia disaster, 2003, all the 13 astronauts who had, could not make it to the surface of the Earth, they all on autopsy had signs of this ebullition. There were multiple gas bubbles within their tissues. So, which means that even if they were provided supplemental oxygen, they would not have survived because these gas bubbles had actually traveled to all tissues of their body.
Super. Amazing. So, Priyank is asking that what about the future travel recommendation if someone has already developed like AMS or high altitude pulmonary edema? So Dr. Ajit, please tell this, that what about future travel recommendations?
Sir, one of the most important risk factor is previous acute mountain sickness somebody is having on the last visit. It is the most important risk factor. Other risk factor is migraine. And other two risk factors are ventilated response to the exercise less than 0.78 liters per minute, or there is a desaturation of more than 22% in response to exercise hypoxia. So if in future travel, if he or she wants to travel again, then he should be using the preventive therapies like ascent of less than 400 meters a day, or prior night stay at the same level. And other precaution is using the therapy like acetylzolamide day before the ascent, 125 milligram BD in terms of prevention, sir.
Prevention. Okay.
Yes.
So Dr. Hirennappa, would you like to add something to this about future travel recommendation? If someone,
it all depends that previous how exactly the life-threatening situation he has faced. So if he is like the patient who has been gone high altitude and got into a hyperbaric chamber and he has been survived, and it is actually a second life for him. And sometimes just saying no for a second time is always a good advice for a future travel. And it all depends. If a small acute mountain sickness and other things are there, we can still advise them to go, and he can become much smarter and follow advice like Dr. Ram said, and carry good hydration, and book correctly with the professionals who can train you to better acclimatize, prepare yourself well, and they can go. But somebody like pulmonary interruption, Dr. Srikar also told. I had a patient who went for a honeymoon. Couple went for a honeymoon, and they had he had a life-threatening this thing. There was a unilateral pulmonary edema, and he was almost intubated and survived. They all said that the PGs who were working there, they said that he will not survive. It is only 67 saturation and all. He made it. He came back. And he was asking question, why I was sick. I was not able to understand why the unilateral pulmonary edema. He wanted the answer for it, and we did the CT pulmonary angio. And there was something called as pulmonary interruption. It's not absent pulmonary, it's called as interruption. We have presented that also. And as Dr. Srikar said, it was a similar case where there was a right side, there is no pulmonary circulation, and you can see the lung which is normal. So he had a high altitude pulmonary edema. It was not manifested on the right side, and he has a unilateral pulmonary edema. Then for these kind of patients, if we have these kind of situations, then we always advise them not to go for a high altitude, because it always puts under a risk. And they saying no is always important. It's in a future trouble, they have a life-threatening attack. For a smaller things, we can make them well prepared and have a successful trip, and we encourage that.
Amazing. So, Dr. Ram, the next question is for you. That what about post-lung transplantation? So, if someone has undergone a post-lung transplant, what are the assessment and precautions for such people for traveling to high altitude? Recently, we had one. This was pretty famous, that one post-lung transplant patient has already traveled to high altitude. So, what is your take on this?
Yeah, obviously, post-COVID, we have seen that there are so many transplantation going on, and obviously, bilaterally, transplanted patient climb up to a mountain higher than 4,000 meters. And before going for the high altitude, every monitor parameter should be checked. That already Dr. Shreeja has mentioned: the heart rate, blood pressure, forced vital capacity, and forced expiratory volume. These things should be tested, and the patient should be at least rested for 6 months to 1 year post transplantation.
Post
At least
transplant.
post transplantation, then only it can be allowed to, whether in the normal conditions. Sometimes it is better that normal post transplanted to up to 2,700 meters. There are evidence that post transplanted patient people can travel it easily. But obviously, that it depends upon again the genetic. One thing that we must have to remember: the genetic and ethnicity also. That which type of whether the patient is prone to in the higher altitude region, or and they have to make sure that is also, so that long transplantation does not necessarily prevent altitude acclimatization.
Okay. So, Dr. Hirennappa, any input from your side on this? That post lung transplantation assessment?
So the post transplant, because I don't see much of a patient with post lung transplant because we don't have a cohorts of patients. Most of our patients are post liver transplant, post kidney transplant patients like that. So I think we can extrapolate there. Usually we look at a timetable of post immune transplant. More than 6 months of transplant, they normally behave like a normal, less immunosuppressed, and this thing because of the travel is being permitted. And in our hospital, a doctor couples, and also they are doing a world tour because they have donated the kidney and transplant patients. They create awareness among the general public, and especially heart and lung transplant patients. Even for the doctors who have been a lung transplant specialists and all, they put their photographs in their podium in their presentations that they have climbed 20,000 feet, 15,000 feet, just to make sure that lung transplant is all well. But most of the time, the lung transplant patients, they carry their immunosuppressive drugs. They are on low dose of steroid, immunosuppressants. These are all important. They are more prone to infections, post-bites, and other things. The disease, what they are into, that has to be taken care of well. So usually, we can allow them because they want to live their life. They would have to get a transplant listed for 5-6 years, oxygen dependent, getting the transplant done, having a successful life. And if they are young, 35 to 50, and we can allow them to go for a transplant. And usually nothing will happen if they have crossed more than 6 months of transplant. And I have seen a kidney transplant, liver transplant patients are surviving 30 years, 40 years with single lung transplant. If they take their immunosuppressants, their due diligence are there. If they don't have a comorbidities, I don't think this should be a contraindication for traveling in a high altitude.
Amazing. Super. So that's a brilliant explanation. And Dr. Shreeja, the next question is for you. That your patient Nitin was a post-COVID survivor, and he had in COVID severe lung damage. So are there any new observations in this new era, which is post-COVID, as far as pulmonary diseases at high altitude are concerned?
Okay, so yes, first of all, post-COVID lung fibrosis and post-COVID obstructive lung disease, I think they should be managed as, how we would manage a restrictive and an obstructive lung disease. Now, as far as any new things are concerned, initially there were speculations in 2020-21 that, patients who stay on a high altitude have lesser incidence of COVID, or that high altitude can be protective for COVID. But later on, studies have been proven that this is not the case. So no, high altitude is not protective for COVID, and the pathogenesis is also totally different. Initially, there were some people were trying to equate that HAPE with the ARDS of COVID, but know that the pathogenesis of both the diseases are totally different. As far as treatment is concerned, again, the treatment is different, except for dexamethasone, which can be used as a prophylaxis for HAPE, and we use it in ARDS of COVID once hypoxemia sets in. Other than that, there isn't much similarity between the two diseases. Now, there's a study that was done in Ecuador that I found on long COVID. So Ecuador is a place with lowland and highland like we have here. So they did a survey of about 8,000 or more people, in which they kind of divided they asked people who got COVID and to tell about their symptoms of 3-4 months after the disease, and they found that about 40 to 50, about 50%, about 49% of the patients in the high altitude had fared worse in the survey as compared to those of the lowlanders. So about 23% of the lowlands people had those symptoms, whereas double of that had, of the people staying in high altitude had symptoms of long COVID, such as, fatigue, cognition impairment, skin abnormalities, hair loss, things like that, and even persistent cough. Yes, about 33% had a persistent cough too. So COVID is in no way in any way good for high altitude or vice versa. And vaccination, like I said in this study, they also stated that 2 doses of vaccines or less increase the chances of having long COVID in patients in high altitude. There is a little bit of literature on, hypoxic, what do you call it? How you basically acclimatize the patient with hypoxemia. So that the people have tried to kind of equate it with the comorbidities, because we have common comorbidities with COVID as well as high altitude diseases like hypertension and obesity can worsen in patients, going to high altitude, as the same way with COVID. So they tried to kind of extrapolate it to COVID, saying that maybe such interventions where we give intermittent hypoxia to such patients, they probably will do better if they catch COVID when they go to higher, altitude. So this is the amount of literature I could find. So if anybody wants to add on.
Dr. Srikar, would you like to add something to this?
Yeah. So, I mean, we can look at it from 2 aspects. So if you just talk about the heart and the lungs post-COVID, so let me talk about the ones who just required oxygen. We are not talking about the asymptomatic or the mild COVID cases. So the ones who required oxygen, who had some amount of pulmonary infiltrates, and whether or not they had fibrosis, if you talk about the lung aspect of it, most of them did have impairment in their pulmonary function testing and a remarkable decline in their DLCO. And the improvement of DLCO was taking almost like probably 6 to 8 weeks. So these guys who are going to travel, they feel that, they have won their battle against COVID. I would actually, repeat their lung function test along with the DLCO, if not as HRCT or whatever, because I won't be learning much from the nature of the infiltrates or the extent of the fibrosis alone, because in this case, or we don't know, but most of the time they say that the people who survived did have some amount of their reversal of the lung infiltrates, even in case of fibrosis. This was observed even during the H1N1. So I would like to repeat that. And also the cardiac manifestations. Most of these guys who had severe COVID did have some amount of LV dysfunction. So if the facilities are available, you can actually do a cardiac MRI, check for the gadolinium uptake, and you find that more than 40% of the individuals with severe COVID had some sort of a abnormality here. So I'd rather, if a person who had recovered from severe COVID wants to go to a high altitude, I would definitely repeat his cardiac markers. I would repeat his TROP-I and NT-proBNP and get a 2D echo done. And for the lung, I would definitely ask him to get, because the long COVID, as far as breathlessness and malaise, fatigue is concerned, it would be nice, but we should make sure that the heart and lung are not contributing to this malaise and fatigue of the patient. So this is how we screen, and the rest, which was very well summarized by Dr. Shreeja, that what exactly did COVID really get, protect? I mean, did the high altitude dwellers get protected from COVID? No, that was not the case, and we had a good literature summary. So this is what I just feel about it. Thank you.
So just to add over here, I feel like this is what I have been following, like many patients, those who come to us in our clinics, post-COVID, those who are survivors, and especially the ones, those who had got the severe lung damage, I advise them a rest of at least 3 months to 6 months before traveling to high altitude. The basic reason, the basic premise of my holding this belief is that it's a prothrombotic state. And we also know that at high altitude, and incidences of pulmonary embolism might be there. So to add 2 things together, which could be more detrimental, causing pulmonary embolism. So just to prevent that, I advise them at least take a gap of 3 months. Then you can plan further definitely after all the evaluation, which all the panelists have discussed. So thank you so much, all wonderful panelists. We had an excellent discussions. And now, since we have completed the questionnaire which we had, I'll just take up the questions which we have been asked. If there are any which are remaining, let me just go through. Okay, drugs for the treatment of high altitude pulmonary edema, we have already checked. And high altitude sickness, why all do not develop? So there is a question. Dr. Hirennappa, can you please tell that why all patients or everyone who is traveling, they do not develop high altitude sickness?
It all depends on the physiology. The physiology is put under stress.
Okay.
Your human physiology is, if you are healthy, and there are a lot of things which Dr. Ram said, it's genetic makeup. And your fitness level, see, you are exercising daily, your age group, and all those matters. It's like a sportsman who is preparing for a marathon. So if you are if you are doing well, and if they are well-conditioned patients, they don't develop it. And sometimes they can develop it because they are overzealous. If they are overzealous, they think that their fitness level is good, and they go on traveling 8,000 feet at a faster rate. They can develop. Normal people can develop. Diseased patients who is really conditions to take the medications, he already know that I can have a complications. He is more safe. He does all the due diligence, and he has a lot of comorbidities. Like he has a diabetic medication, he has a hypertension medication, he is a smoker. He takes his advice properly. He does the things. He may not develop it. So that's why the reason is it's not about the healthy or unhealthy. You do certain things where your stress body is not put under a stress in a high altitude. How exactly you prevent it? How that physiology gets time to acclimatize? That is more important. So it depends on that. Sometimes we have an unusual case. We have a abnormal pulmonary interruption, and this thing that is really unmasked when you are traveling, that we can't help. That's our fate and destiny. And if you have not checked for, you have a primary polycythemia and you have traveled high altitude, you develop a pulmonary embolism. That's a different question. But you would have done a due diligence. So it is really unpredictable. So it all depends on. It's not on one factor. It's a multifactorial regions, right from genetic factors, and you have a pre-existing lung disease. How your conditioning of the body, how you take care of your body, how many times you have traveled previously with the multiple tracks, and that is important. How you carry yourself in the environment of a stressful situation determines your complication rates.
Thank you. So next question, which is coming, Dr. Ram, can you please mention some side effects of this Diamox or acetazolamide?
Yeah, obviously this is also acting as a diuretic, so that we have to think about whether the people or the climbers are getting the appropriate hydration or not. So that we have to think about it also. So that we have to consider those things, that acetazolamide should be prescribed or not, or given to the patient or not. So that we have to think about it, considering the dehydration part. So these are the things we have to say.
Next question, we have already discussed that how to give fitness. Then another question is, Dr. Ajit, can you please tell that who are unfit for high altitude travel? We have already discussed in parts that who are fit to travel and how do we get fitness. So who will be like totally unfit for travel to high altitude?
Sir, basically one aspect we have discussed, like particularly in cases of disease, like in COPD patients and asthma patients, there are studies about some altitude is there. Now we can some Distler's equation is there. Then you calculate the PO2. If PO2 is 55 to 56, then you can contraindicate. That is a contraindication to go up to ascend. One point also I recall right now, like if there is a MI or if there is stenting has been done, then it is contraindication up to for 12 months, sir.
12 months.
Yes, sir, 12 months. Sir, other is a pneumothorax, sir. We have contraindication for at least 2 weeks. You have
at least 2 weeks. We discussed that.
Like this, sir. Other comorbidities, the person with the more comorbidities, that are the contraindications, sir.
Okay, so thank you so much, Dr. Ajit. Shreeja, would you like to add to this any particular patients, those who are unfit to travel to high altitude, apart from what Dr. Ajit has already told?
A previous bad episode.
Yes, exactly. I was going to say that only. A person who's had a past history of, HAPE and HACE, they have to be more careful. I think we already covered the cardiovascular patients with thromboembolic disease.
I think most
Pregnant ladies.
important factor in fitness is pH.
Yeah.
pH.
Right, yes.
Other thing, we've got few hematological conditions, as you had already mentioned, sir. You have mentioned about polycythemia vera, and we also have sickle cell anemia. So the ones who are not really managed,
sickle cell
they
anemia
have,
is also mentioned very clearly.
yes, so they'll have
lymphangioliomyomatosis.
leiomyomatosis.
We have
and
a
also
cystic lung diseases.
Yeah.
We should be careful in giving this thing where the role of CTA, and if somebody is having a bulla in COPD, and
Yeah.
even if their oxygen is good, and they are at high risk.
And also adding on to what Dr. Ajit has already mentioned about stroke. So in case we also may, probably if you have already exceeded that 1 year period, but we do find some AV malformations within the CNS or in the lung, or even a CLD with hepatopulmonary syndrome. Of course, they would not be in a position to travel, but if we do have a AV malformation of any sort, or a aneurysm, also cerebral aneurysm, it is better to avoid. Any benign space occupying lesion also, it's better to avoid. So maybe if you have a meningioma, the person doesn't want to get treated at that point of time and wants to travel, we would generally caution against it until
any hemoglobinopathies or aneurysm in the brain or those things.
So I think we forgot to mention about the eye problems too, like retinal detachment, any recent eye surgeries.
Definitely.
So yeah, I think those also.
Even glaucoma. The glaucoma is also very important. That needs to be kept in mind.
So even if you give the fitness, and there is one more person who is being sometimes if there is a strict there is a aerospace medicine people also there. They do a thorough checkup of all those things.
All those things, yes.
Recently, the aviation medicine people are doing, especially in sleep apnea and other things. They just don't leave you, and it is very tough situations to clear the fitness from them. They do all the cross checks.
These are very, very to the point. Actually, if you go through the forms that they give you, like how you were mentioning, I had an ILD patient who she didn't want to go, but her son's living in the United States want her to come there. And I kept telling them, why don't you come down instead, But they actually got forms from the United Airlines, from Swiss Air, and they have really pertinent questions. Are you sure nothing will happen to her? Questions very succinct questions that you feel such patients shouldn't travel actually. So, yeah.
And we do find, I think, you would be a better judge. There are a few people who love taking risks, sir. So you being a psychologist would be more familiar with that, because when I had visited Leh in 2015, we went as a group, and one couple, basically, the lady wanted to travel to a high altitude despite having nosebleeds and severe acute mountain sickness, and she had to be hospitalized in the military camp there. So, and she had done that on 3 occasions in 3 days. So it's like they somehow love taking risks, and they subject themselves. So probably.
Dr. Srikar, I'm not a psychologist. I've got special interest in psychology.
Probably
those are personality traits.
Yeah, exactly.
Yeah.
So,
by profession, I'm a pulmonologist only.
Absolutely.
Till now.
Dual interest, basically.
No, that will add to make you better pulmonologist only.
Exactly.
One more.
That's true. That's what our patients. That's what our patients keep telling us. There is one question that Dr. Srikar, I would like you to address. What's your take on HAPO bags?
Oh, sorry?
High altitude pulmonary edema bags, which are there.
Yeah. So that one, it's like a good reckoner, because we are subjecting the patient to an immediate descent by increasing the ambient pressure around them. So that would probably help us in administering medication. So because if at all we just look for oxygen and all, it's better we have one in a base camp in a non-medical setting too, so that we just place the patient in a HAPO bag before medical attention can be given to the patient. So place him in and then start the remaining treatment for high altitude pulmonary edema at the same time.
Okay. Fine. So that's all from my side. If there are any further questions, Edwin, can you please let us know?
I don't know the name of the hospital. The best hospital for this high altitude sickness and other things is in China.
Okay.
I don't know the name of the hospital, because that lady has survived and come to me. And
so usually people from China goes to Tibet, sir. And the studies are more from Tibet and China.
And we had a screening in Tibetans. Normally their baseline BP is high. They drink salt tea, salt teas. Instead of sugars, they use the salt in that with the leaves. And they have a peculiar habit. These are low, those are staying in the high altitudes. They have created certain system. Even if they come to low down and stay in our normal community also, their body and genetic makeup as such that they behave like they have acclimatized the patients only.
Okay.
Sir, one of the drug therapy mentioned is Zincoga.
Ginkgo
Maybe
biloba.
I'm not
Ginkgo
correctly
biloba.
pronouncing. That is a more of a Chinese plant type, tea. That is tea made from that. Sir, one of the DD I want to address key. Usually, people goes to mountain. They must be kept in one of the disease alcohol consumption, sir.
True. So again, requesting the admin, if there are any further questions, please let us know. And else, if there are no further questions, so before closing the session, I would like all of the panelists to give their like one word of advice or one piece of advice for travelers to high altitude areas. And we would start with Dr. Ajit, since you are on the screen here. So let's start with you.
Sir, thank you so much, sir. I would like to first thank the CCI and all the respected teachers present right now in front of my screen, sir. Sir, I would like to address a few points that the prior history of acute high altitude illness is the one of the most respected. If a person is having that episode earlier, then he must be precautious next time. Second thing is, sir, single best treatment, the primary treatment is a descent, sir. Whenever there is illness, you as soon as possible go for descent, sir. And other is, sir, slow ascent. At least less than 500 meters a day. And sir, preventive therapy, acetylzolomide, and treatment of choice for HAPE is oxygen therapy.
Oxygen therapy. Okay, fine. Thank you so much, Dr. Ajit, for being a wonderful, wonderful participant as a panelist. And then I'll move to Dr. Ram. Your advice before we.
Yeah, obviously from Kathmandu, there are so many people, all not only the Nepalese, so many people have the dream to visit at least Mustang. It's approximately 4,660 meters from the sea level. Obviously, this is a very good place to visit, and I think we all, but the people returning from there, they have never got any account acute mountain sickness or any high altitude pulmonary edema. So that I can say that beyond 5,000 meters, it's okay for Nepalese people.
Okay. Okay. Thank you so much, Dr. Ram, for being a wonderful, wonderful presenter. And next, I would like Dr. Srikar, your piece of advice which you would like to give.
Yeah. So thank you, sir, once again for this wonderful opportunity. So I'd like to conclude here by saying that it's always, I mean, if you have to give an advice to a traveler who is planning to ascend to a high altitude, first, a good pre-medical check. And after that, follow the instructions at high altitude, because the high altitude is going to penalize you if you don't respect its rules there. So even if you're the smartest ultramarathoner or at a base level, it's always better to follow the rules and make sure that they get acclimatized properly with medication, a slow ascent, and exercise extreme caution. Every new symptom occurring at a high altitude should be taken very seriously. It should not be brushed aside as something which our body is trying to learn to adapt, etc. Okay. And also, in case of any untoward event, whether it's a high altitude pulmonary edema or anything for that matter, make sure we descend immediately. Do not rely on your body to heal itself. Descent and caution is always first.
Amazing. That's true. So, Dr. Hirennappa, sir.
Yeah, it's always good to explore life and environment, nature. It's always good. But it is a challenge to your body also when you are going to certain place, and make sure that when you are testing your body, your all organs has to function well. And for the doctors, it is a very challenging task, because it is outside pulmonology, because it's It's you need to think holistically more about the body, and here when you are giving a fitness, you are not there when to handle the complication.
Yeah.
In surgery and all, you can do a DLCO, you can do all CPAT and do a clearance and all. Post-op, if they are on a ventilator, they will call you, they will chase you, and you have to get clean him off the ventilator. There you are not in the picture. So obviously, when you are giving the fitness, you take into those consideration and really take it and probably tell them no and yes confidently. That might affect them transiently, but definitely it will do a miles good there to their family members.
Definitely. So thank you so much, sir, for being a wonderful panelist. And the last words we will have from Dr. Shreeja.
Thank you, Dr. Ankush.
We have listened about all the advices for all the kind of travelers, and so your piece of word of advice for the doctors out there, those who are
I think that was all that was left to say now, because everybody said everything. First of all, thank you so much to all of you. It was a wonderful 2 hours. So I think for the doctors, yes, especially for our young colleagues, I think you see these diseases are not something that we come across usually. I think we study for our exams, but then when patients come to you, suddenly you're struck with, okay, Abhi, you know it at the back of the mind, but these are not something that you see regularly unless you work in such a setting. So I think, yes, maybe hospitals should designate pulmonologists as the go-to doctors for, advice, so that we have a proper advice to give to such patients, because these kind of recreational activities are very common these days, and people like to venture out, and trekking to high altitudes and all are quite common. So I think this gives us an edge over, so as doctors in this field, that we know more about the, diseases that can affect us in high altitude. So I would say, and maybe we could do more research also in this field. I feel things like hyperbaric oxygen therapy, like the preconditioning things I was mentioning about, if your hospital has that, maybe there is a scope for you doing research on this further to, add on to the, treatment and the management of such patients. So other than that, I think it's all covered.
Thank you so much, Dr. Shreeja, for being a wonderful panelist. In fact, all the 5 panelists today, I had the fortune of hosting you all, and absolute wonderful learning 2 hours these have been. So just last word, which I already mentioned during the session, which I always tell to my patients, that please remember that your life is important. Very, very important. Your travel is absolutely important, but your life is more. So
Very
this is
true.
side, and now over to the CCI team. Thank you so much.
Hopefully our 3 patients have come back with Ajit safely.
They did came back in between the session only.
Yes, sir, we are here.
Thank you.
Thank you so much.
Thank you.
Thank you so much.
Thank you.